Good evening, friends. Thank you so much for this opportunity to speak about the use of actually echocardiography and cardiac emergencies. Why do we need echocardiography? Because in echocardiographically basically looks at the cardiac structure and function. Most of the cardiac emergencies, so to say, when they present in the ER or in the ICU, or when such emergencies arise in the OT or in the cath lab, usually the clinical signs should be actually sufficient. Practically speaking, most of the times it is the junior doctors or the medical officers who look at these patients first. Number one, they have to be very sensitive. Secondly, clinical signs might be very subtle, might not be very obvious. Effusions, fluid collections, LV dysfunctions, etc., might actually mask the clinical signs, and therefore we cannot wait for the signs to become very, very obvious so that we can diagnose a case based on clinical examination and then treat that. Therefore, we need and secondly, echocardiography is such a simple, easy, accessible, cheap, non-invasive tool that you can have it universally almost everywhere in every ICU. So how should we do it? It would not be a detailed sign. At the earliest suspicion of any medic or any cardiac emergency, one should look whenever there is a problem, even if we can get a probable diagnosis, a likely diagnosis, or even if you can substantially rule out certain clinical syndromes, even that is enough. You do not require a detailed clinical examination or a detailed echocardiographic examination. What we should see, we'll see that later. And when and where should you do this? It should be done at the bedside wherever it is possible. So be it the ICU or the cath lab or the ER or in the OT. And it should be done as promptly as the earliest sign of suspicion that there's something wrong going on with the heart. Take up a probe, put it, quickly see, and if at all it's changing a line of treatment, be prompt to do that. So what should be the clinical indications? So hemodynamic instability or hypoxia of unknown cause. So maybe there is cardiac tamponade, a suspicion of acute onset dyspnea and the patient has hypotension, there is tachycardia, but the chest appears clear. So you're not suspecting anything else, and if there is a clinical suspicion, put a probe and check. Or pulseless electrical activity from massive pulmonary embolism, tamponade, a massive internal hemorrhage, tension pneumothorax, etc. Suspicions of aortic dissection when a patient presents with uncontrolled hypertension and excruciating chest pain radiating to the back, where the lower limb pulses are not as strong as the upper limb pulses. In acute coronary syndromes, not only to look for wall motion abnormalities, but also to look for mechanical complications like VSRs or effusions or cardiac ruptures, etc. Massive pulmonary embolism, any valvular heart disease, say for example, a patient undergoing a BMV suddenly develops, hemodynamic traces of acute severe MR, or a patient with lateral or inferior wall MI suddenly has a cardiogenic shock or heart failure, and you suspect that ischemic MR might be the underlying culprit. Whenever you suspect prosthetic valve dysfunction, say a thrombosis, if a patient is not very compliant on anticoagulation use and suddenly presents with acute onset dyspnea, and that is your probable clinical diagnosis, put a probe and check it. Because your line of treatment depends on this. Any acute embolic events, infective endocarditis, or even non-cardiac illnesses like shock, burns, you want to look at the cardiac function, you want to look at the IVC to decide the fluid therapy. So it can also be used as a guide to tell you about fluid resuscitation whenever such situations arise, like say DK or septic shocks. So what should be a basic broad algorithm? Whenever a patient is unstable with shock and pulmonary edema, a quick targeted transthoracic echocardiography, you look at pericardial effusion. Even if it is moderate, if it is rapidly filling, it can cause tamponade. If the IVC is collapsed, that's okay, it's possible. Suspect tamponade, look for it, treat it. If you see a large dilated right ventricle with hypokinesia or akinesia, suspect pulmonary embolism. If you see hypokinetic LV, LV function is poor, then it is the diagnosis is pump failure. Whether it is ischemic, whether it is myocarditis is secondary. Or when you see a hypercontractile heart and a collapsed IVC, then that is a sign of severe hypovolemia or internal bleeding or sepsis. So these syndromes can tell you about what exactly you are dealing with, and it can give you a rough guide to the possible line of treatment. We look at cardiac tamponade. Whenever the pericardial pressure exceeds the cardiac pressure, fluid will keep accumulating, and if it exceeds the RA diastolic pressure, there would be a late diastolic RA collapse, and when it exceeds the RV diastolic pressure, you will see the RV collapsing. That is what we call the tamponade effect. So RA and RV collapse, there is a paradoxical septal motion bulging more towards the left ventricle, so that the left ventricle cavity actually reduces in size. So the diagnosis of tamponade is based on pericardial effusion. Remember, the severity of effusion or fluid collection is not important, because many times even moderate effusion, if it happens rapidly, can lead to tamponade, and even small decompensation by a needle aspiration of even 20-30 ml can lead to significant improvement in the patient's hemodynamics. Look for diastolic collapses of the RV free wall or the right atrium. If it's a large pericardial effusion, the heart would actually swing inside the pericardial sac. You can see the respiratory variation in the mitral and tricuspid inflows, and you can look at the IVC also. So you can see the right ventricle at the top is almost collapsed, and there is a it's not a massive pericardial effusion, it's a moderate pericardial effusion, but it is collapsing the right ventricle. Here you will see a large pericardial effusion and the heart is almost floating freely inside the pericardial sac. So you can have different situations. You can have IVC can be dilated. It may not be dilated if the patient presents quite early. You can look at the respiratory variations. We'll not go into more details. There is a lot of emergencies to follow. And echocardiography not only helps in diagnosis, also helps you in where to put the needle inside. Most of the times it is done as a blind procedure in the subcostal way, but sometimes if the fluid is dependent and not towards that, you might not get good success with the subcostal approach, where you can with good experience and expertise, if you can do a apical tapping, of course echocardiography guided, provided there is more fluid on the left side, you can also drain fluid from that side. So it can help you tapping the fluid also. Regarding pulmonary embolism, you will look for RV dilatation, abnormal wall motion abnormality of the right ventricle, that is called the McConnell sign. There would be a systolic flattening of the ventricular septum which becomes D-shaped. There would be tricuspid regurgitation, the PA pressures increase, IVC becomes congested, the PA is dilated, and sometimes you might see thrombus also. Not always, but sometimes you can see in the RA-RV or even in the PA or in the IVC. So you can see in the left top panel that the LV is underfilled. The septum makes a D shape. On the right top panel you can see it's a D shaped left ventricle in the short axis view. In the left lower panel you can see that the RA and RV are dilated, and in the right lower panel you can see tricuspid regurgitation. So these are all classical panels, and when this supplements your clinical presentation of acute onset dyspnea with tachycardia, engorged neck veins, a clear chest and hypotension in a patient who has been immobile or has recently undergone some surgery, your judgment or your clinical diagnosis of pulmonary embolism is almost confirmed. So sometimes you might be able to see some thrombus or RA myxoma embolizing. All these things can sometimes be present. So you can see a dilated RA and RV. You can see it very clearly that the septum bulges and forms a D shape. The LV becomes underfilled, and sometimes you can see some tumor or a thrombus propping up. You can see the D-shaped ventricle. So these are the classical clinical presentation, and even for pulmonary embolism, the bedside echocardiography is very, very essential. What about just a patient presenting with hypotension? Is the cause cardiac or non-cardiac? Whether it is due to pericardial effusion, is it due to pump failure? So for hypotension patients also, echocardiography provides useful insights. So if it's a cardiogenic shock and you see poor LV contractility, then the diagnosis that it is cardiogenic. If it is hyperdynamic, the ventricles are pumping briskly, then you suspect hypovolemia. If there is substantial dilatation of the RV along with hypokinesia, then you suspect large RV infarcts or pulmonary embolism. If there is a diastolic collapse of the RA and RV, you suspect cardiac tamponade. So in cardiogenic shock, the LV would be dilated, there would be hypokinesia or akinesia, so it can help you in diagnosis. In hypovolemia, the ventricles are briskly contractile, and despite that there is hypotension. For non-traumatic resuscitation, a direct visualization. So is there effective myocardial contractility? Whether there is asystole, hypokinesia normal, if there is substantial pericardial effusion or not. In pulseless electrical activity, remember you do not stop cardiac resuscitation to look at echocardiography. It's just of 1 or 2 seconds in the middle of cardiac massage and chest compressions that you just look at to see what exactly is happening, because your management might get affected. For instance, if there is a large pericardial tamponade, a quick draining of the pericardial fluid can help revive the patient. If it's a brisk wall motion of the heart despite cardiogenic shock or hypotension, then volume resuscitation would be useful. If the RV is dilated, look for pulmonary embolism, look for signs, ECG signs of RVMI along with inferior MI. If there is substantial hypokinesia, then inotropic support might be required. If there is asystole, just continue ACLS as per the protocols. In pulseless electrical activity, also keep in mind that there could be some false positive cardiac motions also, because at the same time there is some cardiac massage going on. The patient is usually intubated and ambuvac is being done, so the visualization might not be so great also. In penetrating chest trauma patients, sometimes in these cases, clinical signs are very subtle, and the signs are not very obvious for the clinician to treat them. And you cannot wait for signs to become very obvious, and therefore it is important to look at the size of effusion or cardiac contractility, etc., to determine whether the heart is involved or not. In acute coronary syndromes, of course, you want to look at wall motion abnormality. You want to see whether the RV is affected or not. You want to look for mechanical complications like ventricular septal ruptures, cardiac ruptures, papillary muscle rupture, ischemic MR, free wall rupture, cardiac tamponade, or LV apical aneurysm, or any development of a mural thrombus. So all these conditions can be very well seen in echocardiography, and therefore in all patients presenting with acute coronary syndrome, a bedside prompt echocardiography is very, very essential. So ischemic MR can also be diagnosed. I'm not going into more details because that would be quite lengthy. You can look for mitral regurgitation. Usually if it is ischemic, usually the posterior leaflet is affected more commonly. So the direction of the jet would be eccentric, facing more towards the backwards. If it is a concentric because of LV dilatation, uniform, then that can happen with cardiomyopathies. So it can give you clues about the underlying possible etiologies also. Regarding aortic dissection, uncontrolled hypertension, chest pain, excruciating, sudden in onset, look for echocardiography. If there are high-risk features like wall motion abnormalities, pericardial effusion, a dilated root, there is aortic regurgitation, you strongly suspect aortic dissection, you shift the patient to the CTOT and you take prompt action. If there are no such features, or you do not see any clinical signs, then you might require to go for transesophageal echocardiography also if required, and sometimes CT aortography also if the clinical suspicion is very strong. So transesophageal echocardiography can also be done at the bedside, which is very prompt, and it does not require a lot of expertise. It is quite sensitive, 95 to 100%. The specificity is also fairly good. The disadvantage, it might require a little bit of sedation, especially in patient who is in a critical emergency. It is slightly invasive, minimally invasive, so you can say, and there can be certain blind spots also. So it's not a 100% thing. But you can look at the true lumen and the false lumen. You can differentiate. Sometimes the true lumen is smaller, the false lumen is bigger. But the true lumen will have systolic expansion. The antegrade flow will be early and brisk, whereas the flow in the false lumen might not be very brisk. It would be delayed. It would be slow. It will show some systolic expansion. So you should be able to differentiate which is a false lumen, which is a true lumen, which branches are arising from the false lumen or the true lumen. So that can help you decide the severity of the situation. So you can also look at the entry points if it is especially iatrogenic in nature. So you can see this trace where you can see a very clear false lumen, a false passage. Similarly, here you can see a true lumen and a false lumen. The false lumen is slightly on the upper side. You can also see it extending towards the abdominal aorta, and you can see a flap very, very clearly in this situation, just above the aortic valve. Here you can see the true lumen and the false lumen very, very clearly. So sometimes you can be able to diagnose it very, very nicely, and you can see. In cases of prosthetic valve thrombosis, if the patient is non-compliant, the INR is persistently subtherapeutic, Especially if there is LV dysfunction, LA is hugely dilated, there is spontaneous echo contrast, more chances of prosthetic valve thrombosis. If such a patient presents with an acute onset dyspnea or cardiogenic shock or heart failure, your suspicion should be very, very strong, and echocardiography will virtually clinch the diagnosis. Not only would you be able to see the thrombus, you can also assess the gradients, and that can help you guide therapy also. Whether you just plain IV heparin is okay, or you would require thrombolysis or a redo surgery. Looking at the hemodynamic factors and the thrombus burden, of course. So look at valve mobility, look at the presence of thrombus, look for the flow across the prosthetic valve, whether it is central, whether it's centric, because whether it's, and what kind of a valve was it. For example, certain valves, bileaflet valves will have lesser structure than unileaflet valves. So you can sometimes see the thrombus, sometimes it is so obvious. Most of the times it is quite obvious, so you would not perhaps miss the diagnosis in such situations. So the take-home message is that echo, yes, tells you about the cardiac structure and function. There are abrupt changes in cardiac structure and function accompany a lot of cardiac emergencies, but sometimes the clinical signs are not so obvious, they are subtle, and you cannot wait for the signs to become obvious to initiate treatment. Many times the person sitting there in the ICU or in the ER is not the best person available in the hospital, the clinician with the best clinical acumen. So echocardiography adds complementary value to whatever clinical basic skills that he has. It might not tell you sometimes the diagnosis, but it can substantially help you many times to rule out the diagnosis also. So clinical decisions, this is not a substitute to clinical decision making, a prompt history and a clinical examination, plus a bedside prompt echocardiography will help you in managing cardiac emergencies quite effectively. So it can provide valuable insights in a lot of situations. Thank you so much for this listening.